In this chapter, we'll discuss the endocrine system. If you remember, we referred to this earlier as the slow messenger system. First off, let's define what the word endocrine is referring to. There are several types of glands: paracrine glands, exocrine glands. The term exocrine gland is spelled like this, and an example would be an oil gland in the skin. It will look something like this. And so this passageway is referred to as a duct, D-U-C-T. So an endocrine gland does not use that. An endocrine gland will actually simply release its components right out into the bloodstream. So for this reason, we're going to refer to this as the endocrine system having ductless glands. The term hormone is derived from words that meant to set in motion. So again, this is our slow messenger system. And a hormone is basically a chemical messenger. It's going to be secreted directly into the bloodstream, and it's going to be carried to basically all parts of the body, and is going to act on target cells. A target cell has to have a receptor. Without a receptor, there will not be any effect. So if you release, for example, testosterone, and it's going to be bathing all the cells in your entire body, but unless those cells have a receptor for that hormone, it's not going to have any effect on those cells. Hormones are carried in the bloodstream in one of two ways. They can be simply circulating freely, or they can be attached to proteins. Proteins will add bulk to a hormone, and this is going to make it a much larger molecule, and it's going to be harder for this to leave the bloodstream through the capillary walls. So for this reason, the hormones that are bound to proteins will stay in circulation for a much longer period of time. Some hormones need to be used up immediately. Think about things like epinephrine, but there'll be other things like growth hormone that needs to have a slower, longer lasting effect. Chemically, hormones can be derived of amino acids. They can be composed of peptides and proteins. Remember, the term peptide simply means a piece of a protein. Or they can be a lipid derivative, and the lipid derivatives classification is going to include the class of steroid hormones. If you look at the chart to the right, you will see that the amino acid derivative, sometimes referred to as simply amines, there is your amine group right there. They're simply derived from an amino acid, and then the peptide is simply going to be a short chain of amino acids that are hooked together, and then a protein hormone will simply be a larger hormone that's composed of longer chains of amino acids. And then again, the steroid hormones, these are going to be lipid derived. And they include hormones such as the sex hormones, testosterone and progesterone. There's a very important distinction between the steroid hormones and the non-steroid hormones, and it's based on how they interact with a cell. A steroid, again, remember this is going to be a lipid-derived hormone, and that means it's going to be lipid-soluble, so it can move very easily through membranes. Remember, the cell membrane is, we talked about as being a bilayered phospholipid membrane, and so things like lipids will move freely across that. So steroid hormones, they will leave the bloodstream, and they will go directly through the cell wall, and then they go directly into the nucleus, and they will have a direct effect on the DNA there. So this is going to affect the messenger RNA, and it's going to end up affecting the proteins that the cell will be putting together. If a hormone happens to be non-steroidal, as one of the protein or amine type hormones, these are going to be water soluble. They cannot penetrate the cell membrane, and so they have to use a receptor which will be located on the outer membrane of that cell. What will happen is, again, the hormone is going to be leaving the bloodstream, but it's going to bind at the receptor level. That's going to trigger a series of activations using molecules inside the cell, inside the cytoplasm, known as second messengers. So these hormones up here, this would be a first messenger. Boy, my stylus writing is getting worse all the time. So again, because a nonsteroidal hormone cannot penetrate that membrane and go directly to the nucleus like a steroid hormone has, you have these receptors that are located on the cell membrane. And you have second messengers, and sometimes even third and fourth messengers, inside that cytoplasm. And so instead of altering the function of the construction of the protein by altering the DNA, and therefore the structure of the RNA, the protein here is going to be altered inside the cytoplasm. So in this diagram, what you're seeing here on the left is going to be the steroid hormones, and again, these guys can just penetrate straight on through and go to work on the DNA. That way, these protein hormones, or non-steroid hormones, this includes the amines and the peptides, etc., they have to have these receptors, and they're going to be activating here as a second messenger, then a third messenger, etc., and they'll actually be working in the cytoplasm. We talked about negative feedback loops early in the first chapter, and the endocrine system depends on negative feedback loops to know when to stop producing a hormone. And in the example here, they're talking about the imbalance being of the hormone glucocorticoid. And so you start with an imbalance. It's going to be detected. It's going to cause release of a hormone known as corticotropin-releasing hormone from the hypothalamus. That's going to cause the adrenal cortex then to correct the situation by releasing glucocorticoids. Those will go in the bloodstream, and the sensor says, hey, I've got enough, you can stop producing it. So it will turn off the stimulus that caused the hypothalamus to release a CRH. So now you are back in a homeostatic range. This is a schematic of the major endocrine systems of the body. There are some smaller systems. There are actually a lot of hormones still being discovered. There's a lot of research of things that we didn't know were having hormonal activities in the body. But we're going to start at the top and work our way down. We'll start off by talking about the pituitary gland. This gland seems to have a huge effect over a whole series of glands, as we'll talk about as we go through these slides. So remember, it sits in the sella turcica of the sphenoid bone, and we talked about it in the brain because it sits right below the hypothalamus. The pituitary gland has often been referred to as the master gland, which I've always thought was kind of interesting because it is under control of the hypothalamus. Again, it sits in the sella turcica and is attached by a stalk that contains a set of capillaries that gives it a portal circulation to the hypothalamus. The old term for the pituitary gland was hypophysis, but you don't really use that very much anymore. So there are two different lobes of the pituitary gland, an anterior and a posterior. On this diagram, you'll see again the hypothalamus, and you'll see that little stalk, that little connection referred to as the infundibulum, and there you see the anterior and posterior lobes of the pituitary gland. The job of the hypothalamus is to release hormones. I was actually taught to call them releasing factors instead of releasing hormones, simply because it kept things a little bit straighter. But the hypothalamus is sending these hormones to control the release of other hormones from the pituitary gland. So that's one of the reasons the portal circulation is so important, because it gives you a direct pathway from the hypothalamus into the pituitary. Here's an overview of the hormones produced or secreted by the pituitary gland. If you look at this, just as an overview, and again we'll discuss it individually more on upcoming slides, you'll see that the hypothalamus actually is the source of ADH. ADH is actually made there. It's simply stored and secreted by the pituitary gland. For the anterior pituitary gland, it's going to be under direct control of the hypothalamus because of all these releasing hormones. So these hormones are going to be released, and they're going to directly affect the pituitary gland, and then the pituitary hormone is going to affect different target organs all over the body. So what I would expect you to pick up from this PowerPoint is going to be the relationship of the axis going from the hypothalamus to the pituitary and then down to the target tissue itself. And then you should also know the effects. So you've got the hormones, you've got the target tissue, and then you've got the effects. The anterior lobe of the pituitary gland is also referred to as the adenohypophysis. So while we don't really use the word hypophysis anymore for the pituitary gland, we do use the word adenohypophysis. So you see the hypophysis right there. The prefix adeno simply means gland. So the anterior lobe is going to be producing hormones from endocrine tissue as opposed to some of the neural tissue that's going to be producing the hormones for the posterior hypophysis. So be sure to understand that the adenohypophysis will be activated by releasing hormones that come directly from the hypothalamus. This is the portal system I mentioned earlier, and it's connecting the hypothalamus down to the anterior lobe of the pituitary. If you recall what a portal system is, it is a series of capillaries that connect to a vein that expand back to capillaries again. Remember, normally you would have a system of capillaries that would go directly to a vein, and then that will go to the heart, and then it come out as arteries, which would go back to the capillaries. So, however, with a portal system, you have a capillary that goes to a vein, that goes back to capillaries, and then it goes back to veins. So the only time you have this, you've got it two times. Remember the hepatic portal system that's connecting the absorptive surfaces of the small intestine to the liver, and then you have it here connecting the hypothalamus to the pituitary. And again, they're very unique, and it's when you need a very, very close association of substances from one region to another. And again, in this situation, it's going to be because you want the releasing factors to have very quick access to the anterior pituitary. Here's an overview of the hormones we're going to be discussing one at a time. But remember, you're going to start out with the hypothalamus producing the releasing hormones, and they go to the pituitary, and then the pituitary will release these hormones. And then these hormones will go to specific target tissues. And I expect you again to know this axis and know the target tissue and know the function. So we'll be talking about growth hormone and prolactin, thyroid stimulating hormone, adrenocorticotropin, ACTH, follicle stimulating hormone, luteinizing hormone, and melanocyte stimulating hormone. So one of the things you'll see, sometimes it'll be pretty simple, the growth hormone. The preceding hormone will be simply growth hormone releasing factor. Thyroid stimulating hormone would be stimulated by thyrotropin releasing hormone. ACTH will be stimulated by adrenocorticotropic hormone. And the only thing that's really kind of different is for these two sex hormones here, or the ones that end up in the sex hormones, their releasing hormone is referred to as GnRH, gonadotropin releasing hormone. Growth hormone is a peptide hormone that's targeting the musculoskeletal system, and it does so by increasing the manufacturing of protein that's going to be needed for growth of muscle and bone. I put this guy down here. You may have seen in the years past in magazines, this guy advertises, he's an MD, and he advertises these rejuvenation clinics, especially targeted toward middle-aged and older men. So he says he was looking like this one day, and he decided he was not happy with it, so he started looking and researching into what he could do to reverse it. And basically he started playing around with growth hormone, and now for a few $100,000 you can go stay at one of his retreats, and they'll give you injections of the growth hormone, off-label use, and you get a little bit prettier. So the problem is with using growth hormone, it does generate muscular regrowth. You know that as you age, one of the things that you do, you replace muscle tissue with fat. Libido drops. You just, your skin is not going to be as smooth and resilient as it was when you were younger. But growth hormone can reverse that. But it can also potentially stimulate heart disease and production of, or an increase of any metastatic cancers that might be growing on that you don't know about. So it's a little bit risky. It is definitely an off-label use, which means doctors really aren't protected from a medical malpractice standpoint if you have some sort of undesired effect. I just wanted to show you this slide to kind of give you a schematic of what's happening here. Again, you're going to have release of the releasing hormone from the hypothalamus. So you've got your growth hormone releasing hormone. That's going to travel through the portal system down to the anterior pituitary. It's going to cause release of growth hormone. Growth hormone is going to break down fat cells to release fat, which is going to allow faster production of growth. And it's going to affect all of these different cells here. So one of the things you'll also see is it causes the liver to produce a series of factors, including IGF, which is insulin growth factor. So they're just recently in the last 10, 20 years doing the IGF research. So people are, along with using growth hormone, they're also using things like IGF-1 supplements, thinking they're going to be increasing health benefits and muscular activity, etc. But again, it's kind of walking on the wild frontier. It's not necessarily I'd want to experiment with. One of the side effects that they have is sudden onset hypoglycemia. But once the levels of IGH get high enough, then the hypothalamus will pick it up, and it will actually then create a hormone that will stop the hypothalamus from producing any more of the releasing hormone. And basically that is the end of the negative feedback loop. So I'd also like you to be able to recognize what goes wrong with imbalances of these hormones. And in this case, if you have production of an inadequate amount of growth hormone as a fetus, as a child, you'll end up resulting with dwarfism. So if you have excessive production of growth hormone as a fetus and as a child, you will end up with giantism. If you have excessive production of growth hormone as an adult, then you simply end up with large hands and feet, large appendages, and that's referred to as acromegaly. So these result from fetal and childhood imbalances, and then acromegaly as an adult. If you have a child that is well under the normal growth curve, it's become a very accepted technique to actually supplement them with growth hormone injections. Of course, it has to be done while they're still having the open growth plates so they can get the effect of the linear growth. I just thought I'd throw this in here. This is a photograph of the world's smallest man with the world's largest man. The target tissue of prolactin is mammary tissue. And so don't get this confused with one that we're going to discuss later that's going to cause release of milk or milk letdown. This is going to actually encourage the growth of mammary tissue itself pre-birth. So this is why your breast would enlarge really very early pregnancy and continue to develop the architecture internally that's going to need to produce milk. The next hormone I want to mention is melanocyte stimulating hormone. So this is going to be stimulating production of melanin by the melanocytes in the skin. This is more important in toddlers and children than it is in adults, because later the melanin production is going to be stimulated more by UV radiation. So when you get a suntan, for example. So be careful with the term melanin. Do not confuse it with the term melatonin. We'll discuss that a little bit further down the presentation. Let's look now at the thyroid gland, and again remember that you're going to have a thyrotropin releasing hormone. That's going to stimulate the pituitary to produce TSH, or thyroid stimulating hormone, and that's going to stimulate the thyroid gland, sitting right here in the lower neck, to secrete thyroxine or thyroid hormones. There's actually a couple of different types chemically, T3 and T4. When you do a blood test, could actually be looking at TSH, T3, and T4. These have a widespread effect all over the body, and their general function is to increase metabolism. There's a couple of major types of cells in the thyroid gland. The follicular cells are the ones that secrete the thyroid hormone thyroxine. This hormone is iodine-based, so if you have an iodine deficiency, you're not going to be able to produce normal amounts of the thyroxine, T3 and T4. This is actually transported in the bloodstream, bound to a protein, as we discussed, because that's going to extend the longevity of the hormone in the bloodstream. So overall effect is going to increase metabolism, which is reflected by increased heart rate, increased temperature. Somebody with excessive thyroxine production might be a little bit hyperactive because it's going to affect the activity of the nervous system. The other cell type of a thyroid gland is referred to as a parafollicular cell, or a C cell. They produce a hormone called calcitonin. Calcitonin is going to stimulate the osteoblasts in bone and is going to reduce circulating calcium levels. So that's going to take the calcium from your bloodstream and drive it into your bones. And you would see this secreted if you have a really nice, adequate supply of calcium in your diet. And then this is amplified with the effects of exercise. So calcitonin will lower blood calcium levels because it's using osteoblasts to embed that calcium and phosphate into the bone. In a fetus, hypothyroidism results in a condition referred to as cretinism. This results in dwarfism. It can result in defective mental abilities. And one of the characteristics you'll see in an infant is their tongue will kind of protrude from the mouth. In the adults, and this is actually not uncommon, especially in middle-aged women, you'll have unexplained weight gain, thinning hair, thinning eyebrows. You'll feel lethargic, no energy. You'll be cold, especially your hands and your feet. You tend to be constipated. You have a hard time focusing on things. And you also have sort of a generalized puffy appearance that is referred to as mixed edema, which is an accumulation of subcutaneous fluid in the tissues, and so you end up with this very puffy looking face, especially around the eyes. One of the things I'll point out is postpartum, after you've given birth to a baby, the thyroid gland takes a little while to get back up into normal gear, and it's not uncommon for women to be hypothyroid. And they talk about mom mind, and they think that this is one of the reasons that a new mother, beyond being just tired because she's not getting much sleep quite often, but she may have trouble thinking very clearly. I wanted to show you what a goiter looks like, and these are fairly extreme cases, obviously. But goiter is the big reason that they started putting iodine in commercial salt in this country. So if you had an iodine deficiency, what would happen is you can't produce the hormone thyroxine, and so your blood levels, your thyroid blood levels, will be low. So the hypothalamus is getting a signal to produce thyrotropin-releasing hormone. That's going to stimulate the pituitary to keep producing TSH at higher and higher and higher levels. So the thyroid-stimulating hormone, the TSH, is going to be stimulating thyroid activity. The thyroid is trying very hard to produce thyroxine, but it's failing. But the TSH will cause the thyroid gland to get bigger and bigger and bigger. So in most cases of thyroid gland, it's actually from a low level of iodine, which results in a high level of TSH, and then a low level of the thyroid hormone T3, T4, or thyroxine. Hyperthyroidism is referred to as Graves' disease, and one of the things you'll see is kind of a characteristic bulging of the eyes that's referred to as exophthalmos. The person tends to be a little bit hyper. They lose weight no matter how much they eat. Their heart rate will be high. They tend to have high blood pressure. Their body temperature might be a little bit higher than normal, and they often have GI signs such as diarrhea. As I mentioned earlier, hypothyroidism would be pretty much the opposite of these signs. As far as with hypothyroidism, you'd have weight gain, lethargy, slower heart rate, lower blood pressure, and constipation. The next hormone that we'll talk about being released by the adenohypophysis of the pituitary gland is going to be ACTH, adrenocorticotropic hormone. So adrenal as in adrenal glands, cortico as far as the cortex of the adrenal glands, and growth. So this is a hormone that's going to stimulate the adrenal cortex. Here's a diagram of your axis. You've got the hypothalamus producing corticotropin releasing hormone. Then that stimulates the pituitary to release ACTH, adrenocorticotropic hormone. That's going to stimulate the adrenal cortex to produce the hormone cortisol. Let's talk about the rest of the adrenal cortex and the products that it secretes. Remember, the adrenal gland is a little cap that sits right up on top of the kidney, which is why they call it the adrenal gland. Sometimes you'll see it referred to as suprarenal gland. It's the same thing. Like many other structures, including the brain and the bone, the adrenal cortex is the outside, just like the cortex of a bone or the cortex of the brain, and the medulla is the inside. The cortex, when you look at it microscopically, it can be divided into 3 different zones, and I would expect you to know each zone and what they produce. First off, the outermost layer is referred to as the zona glomerulosa, and you may recognize the word glomerulus in there. This is going to produce the hormone class mineralocorticoids, and we'll talk about those in just a second. The middle layer is the zona fasciculata, and here is your cortisol that we mentioned on the previous slide. This class of hormones is referred to as corticosteroids. So the zona reticularis, they produce basically male hormones, which is androgens, sometimes referred to as gonadotropins. Zona glomerulosa produces a class of hormones referred to as mineralocorticoids, and they're named because they regulate mineral secretion and absorption by the kidneys. The big one is aldosterone. This is going to be a sodium saver. So one of the things that you'll learn is that your body cannot move water. Imagine trying to go up to the edge of the ocean and kind of catch water with your hands. It's going to run through your fingers. The same thing happens with the cells. Water simply moves across the cell membrane very freely. So the way the body manages its water release and reabsorption is by manipulating sodium. So you can always remember that water follows salt. So when we say salt, we think typically of sodium because it's one of our most important electrolytes in our body, also potassium. So aldosterone is going to increase the amount of sodium that you resorb at the level of your kidneys. It's going to increase the amount of potassium you get rid of. It's also going to make you thirsty, and it's going to make you more sensitive to the taste of salt to try to get you to be encouraged to drink more water. So your body will produce aldosterone and release it from the adrenal cortex in response to low blood volume or low blood pressure. Just an FYI, the release of aldosterone can also be triggered by low sodium or high potassium. So one of the things that you'll see recommended by physicians for treatment of high blood pressure is to use, instead of using table salt or sodium chloride, to use light brand salt, Lite. This is actually potassium chloride instead of sodium chloride. So my dad is one of these that will always use way too much salt. So he has this put in front of him in front of meals at mealtime. And so before he even takes a bite of his food, he just grabs a salt shaker and just starts dumping it on. It's dangerous because if you have a really high consumption of potassium, what's going to happen is you're going to trigger release of the hormone aldosterone, which is going to increase your sodium conservation, which is going to act to increase your blood pressure even more. So there have been cases of people dying that were treating their high blood pressure and simply made it worse by using things like the light salt. Glucocorticoids are produced by the zona fasciculata, and the word fascicula simply means to tremble. And so one of the things that I'll always remember, I had a massive dose of, in fact, several doses of corticosteroids when I was in college. I was having a reaction to the antibiotic erythromycin. and I broke out in the most miserable case of hives from my head to my toes. And I had these huge, angry red whelps all over my body, and I was just itching till I wanted just to die. And so they gave me some prednisone, which is a corticosteroid. It didn't do enough, so I'm like, please give me some dexamethasone. They gave me some of that. And one of the side effects that happened to me in the middle of the night is I really just could not stop trembling. I had a good case of the shakes all over. So every time I think of zona fasciculata, I think of that night. So cortisol, you'll also see it referred to as cortisone. Don't get bogged down in the chemical variations of this. Different books use terms corticoids, glucocorticoids, cortisol, cortisone, pretty much the same chemical class. The effect of these hormones is to allow you to handle stress. So the problem is, a few hundred years ago, our stress was a physical stress. We had to run from a predator. We had to go out and actively seek food supplies. We had to work hard to build our shelters. Now the stresses that we have are very sedentary stresses. You might be stressed from a job. You might have relationship stress. You might have stress because you're taking anatomy and physiology. But again, there are stresses that are parts of a sedentary life. We're not getting any physical release of this. But your body doesn't realize that, so it still releases the cortisol. The effects of the cortisol is to increase blood pressure, blood sugar. I'm going to get to blood pressure in just a second. I was going to increase blood sugar because it's, again, thinking that you need the energy to run away. It's going to increase blood pressure, again, trying to get more blood to your skeletal muscles, letting you escape that predator. It's going to reduce the effects of your immune system. So if you have an injury, you're not going to heal as well. So think about the fact that you're running away from an angry bear. You're going to have a high blood sugar to help you run. You're going to have a high blood pressure to help you run. You're going to be having a very open airway. You have a bronchodilation. And if that bear would reach up and grab and rip off your left buttock, then you could keep running for a longer period of time because you're not going to get stiff and sore. So the problem is, again, we have sedentary stress. We're not using our extra energy and blood pressure. And what can happen is, if you have this chronic stress that goes on, it's not relieved, you can have diabetes, you can have hypertension, and you will be very susceptible to every sort of viral infection that comes down the road. So you may have had times in your life where you had all these stresses going on. It seemed like you were always catching a cold, etc. And that is perhaps because you had a chronic overproduction of corticosteroids because you were feeling the effects of stress. A little stress is a good thing. A little stress can motivate us. It makes us get out of bed and go to work in the morning. A little bit of stress makes you study for your exams. But chronic stress can indeed kill us. So a term you should know is Addison's disease. If you are an Addisonian patient, then you have adrenal insufficiency or hypocortisolism. So you will see weight loss, weakness, low blood pressure. One of the characteristics is you'll have darkened skin in areas that aren't normally exposed to the sun, for example, the gums and the armpits, etc. So this happens if you're not producing enough cortisol, and sometimes if the effect of adrenal insufficiency is wider, you might also have a lack of enough aldosterone, which would make sense because that would be related to the low blood pressure. Here are some of the external signs in Addisonian patients that I mentioned as far as the darkening of the skin in non-exposed areas. Cushing's disease is hypercortisolism, is overproduction of corticosteroids. And I'll talk about, you can actually have what they refer to as exogenous Cushing's in just a moment. So you will see these patients being overweight. They tend to be a diabetic. They tend to have high blood pressure, which goes along with what we talked about a couple of slides ago. They have a very characteristic round face. You might have a lot of fat around the neck, and around the back. But you tend to have thinner arms and legs because you've got muscle wasting. You've got weakness, again, high blood pressure, high blood sugar. You'll also because of the aldosterone effects, you'll be peeing a lot and drinking a lot. I used a term on the last slide, exogenous Cushing's. So when something is exogenous, it means it comes from outside of the body. So on the previous slide, we talked about just general Cushing signs that can result if somebody's body is producing too much cortisol. But there more commonly are cases of what they refer to as exogenous or iatrogenic Cushing's syndrome. So iatrogenic simply means that it's being created basically by the physician, although in a lot of cases it'll be because somebody is self-medicating. So prednisolone and prednisone are commonly used to treat just about everything, any sort of allergic condition, cases of asthma, cases of poison ivy, anything that's usually miserable. Prednisone or prednisolone will make it feel much better. Even if you have a really bad cold, if you go to seek treatment, one of the things they'll do if your throat's really sore is they'll give you a dose of a long-acting steroid because, again, it reduces inflammation. It makes you feel better. The problem is if you take it for a long period of time, your body is going to actually develop signs of Cushing's. But on the other side of that, your body will actually stop producing its own cortisone, and so therefore you can't simply stop it without being weaned off of it. In other words, if you take prednisolone every day for a month at the same time or that same dosage rate, what's going to happen if you stop suddenly, you'll actually go into a self-induced Addisonian case because then your body has stopped producing it. Now you stop taking the pills and poof, you bottom out, and that becomes a very dangerous condition. So normally what will happen if you were prescribed the corticosteroid type hormones, they'll give it to you at a high dose for say about a week. Then you'll start reducing the dose down. You might go from say 20 milligrams for a week, then you might go to 15 milligrams, then you might go down to 10, then you might go down to 5, and then at the end of that, you might stay on it every other day for a period of time. So that might be an extended schedule if somebody's treating something long term. But things like rheumatoid arthritis, any of the autoimmune diseases like lupus, all of those things are helped by prednisone, but the side effects can be pretty devastating. So they tend to not use it unless they really have to. So it's an inexpensive drug. It's probably one of the, in fact, it really was the first drug they used to treat cancer patients because, again, you feel better, you're reducing inflammation, and it did seem to, for a while, reduce the swelling associated with certain types of cancer. One of the things I always think about when I was in veterinary school, I worked for small animal vets as a student. And living in the deep south, there's a lot of things that dogs can be allergic to, pine, pollen, and that sort of thing. And plus, you have fleas on top of that. So you would have somebody come in, let's say a little poodle, and it's always scratching and it's making the owner miserable. And so the easiest thing to do would be give the dog an injection of cortisone. Well, the dog stops scratching, the dog seems happier, the owner is happier, and the cortisol wears off in, let's say, a month or so. They bring the dog back in and they want another shot. And so if you've got somebody who's doing bad medicine, they just kind of keep on going because it's the easiest, cheapest thing to do. And the next year you'd see the dog, and the dog would be very pot-bellied. He'd have very, very thin legs. He'd have a swollen abdomen. He would have alopecia, in other words, hair loss across the sides. And so just really wreaked havoc on the dog's body. And the same thing happens with people. I've seen people who had their joints chronically injected with cortisone repeatedly over a period of months, and they'll end up with thinning skin. They bruise very easily. So, again, steroids can be a wonderful thing, but it's not something that you can continue on for a long period of time without serious damage. And then finally, the zona reticularis. Again, these are going to be producing what's primarily thought of as male hormones or androgens. And these kick in and provide the secondary sex characteristics at puberty, such as the deepening voice in males, breast development, and buttocks development in females, things like hair growth, legs, arms, and pubic area. Since we've already talked about the adrenal cortex, let's go ahead and talk about the hormones of the adrenal medulla. This is referred to as being sympathomimetic, which just simply means it mimics the sympathetic nervous system. The neurotransmitters that we talked about from the sympathetic nervous system with the adrenal medulla, they're going to be actually now hormones, epinephrine and norepinephrine, sometimes referred to as catecholamines. So again, just like with the sympathetic nervous system, you're suddenly frightened, you feel the need to run away, escape. These hormones won't let you do this. These are your fear and anger induced hormones. And very similar to what you saw with the cortisones, you'll have a high blood pressure, a high heart rate, your heart rate pounding. You've got the vasoconstriction going on, producing the increased blood pressure. You're going to have increased blood sugar, and you're going to actually decrease the amount of activity going on in your GI tract. The last thing you want to do when you're really, really afraid of something or really upset is to think about digesting the sandwich you had for lunch. So this is why, if you've ever been a little nervous, you might not want to eat anything. You've got butterflies in your stomach. Sometimes, especially with women, if you're traveling, you actually will go for like a week at a time with no bowel movement because your GI tract is just not functioning normally. So if you're really upset, you might actually end up getting nervous and throwing up, and it can actually even go to where you're so afraid you actually, as the saying goes, you poop your pants. What's happening is your body is trying to offload that extra weight so you can run faster, you can escape the marauding bear or whatever, and you're shunting your blood away from your GI tract so it can go to your heart, your lungs, and your skeletal muscles so you can escape that danger. Okay, let's go ahead and move into follicle stimulating hormone, or FSH. In the woman, it's going to stimulate the ovaries to produce estrogen, and in men, it's going to stimulate sperm production. So this is going to be stimulated by the release of GnRH, and again, I mentioned that this is your axis here. GnRH from the hypothalamus will result in release of FSH from the pituitary, which results in estrogen and sperm production from the woman and the man, respectively. Estrogen is active in sexual receptivity. You'll actually see a spike in estrogen a little bit before ovulation, and so about mid-cycle, which is when ovulation happens, you're going to actually be a little bit more interested in having sex. So there's all sorts of little biological activities that will happen that you may not be aware of. Statistically speaking, you are more likely to wear red clothing around mid-cycle, around ovulation, and that the color red is associated with romance and sex. And so again, the behavioral biology can be pretty interesting. Luteinizing hormone is referred to as LH quite often, and it's going to be responsible for production of progesterone from the corpus luteum on the ovaries in the female and testosterone in men. So when we get into the reproductive chapter, you'll see what happens with, you have an ovary, let's be real simple here with it, and you will have a little blister-like structure known as a follicle, hence the FSH we talked about in the last slide, and it contains the ovum or the egg. So at ovulation, this follicle is going to rupture, release the egg, and it's going to migrate seeking a sperm somewhere, and this structure is going to then become what's known as a corpus luteum. And the corpus luteum is going to produce progesterone, which is going to feed back to tell the uterus, hey, build a nest, I've got us a baby coming. So we'll talk again about the cycle when we get to there, that chapter about reproduction. But what happens with the uterus is the endometrial lining becomes very thick and plush, hoping that a fertilized egg is going to land there. If you don't get pregnant, what's going to happen is that lining will break down and it's flushed away when you have a period. One of the big functions of progesterone is to help maintain pregnancy. So again, what happens, we talked about earlier, on the ovary, you've got now that corpus luteal structure producing progesterone. And if you do happen to get pregnant, this is going to keep on producing progesterone till about the first third of the pregnancy ends. At that point, the placenta is going to take over progesterone production. But it keeps the myometrium, the muscle of the uterus, nice and quiet and relaxed, and basically not reacting to the hormone oxytocin, which we'll talk about later. So what you'll see around time of delivery, you'll see progesterone drop and you'll see estrogen increase. LH also results in the production of testosterone from testicles in males. This is responsible for the libido, the sex drive in men, and also muscular and bone growth. Testosterone is one of the anabolic steroids, and you'll see it abused quite often with people who are taking anabolic steroids for building muscles for weightlifting and that sort of thing. There is a condition known as roid rage, and you'll actually see these people having very destructive fits of rage. There have been cases of murder blamed on that. One of the things that I'm always wanting to point out is if you take a supplement like this, just like we talked about with the cortisol, your body will decide, hey, I don't need to produce this. You're going to give it to me from external sources. So what will happen in the case of testosterone or anabolic steroid abuse, one of the side effects is shrinking testicles. Now let's go ahead and move to talking about the posterior pituitary, which is also known as the neurohypophysis, and is referred to as the neurohypophysis because you actually have hormones being secreted by neurons. So there are two hormones secreted here, ADH, antidiuretic hormone, and oxytocin. Antidiuretic hormone is going to make you retain more water. So diuresis is production of urine. So antidiuresis then would be not producing urine. So if you're dehydrated, if you need to preserve your water content, let's say you're not drinking enough water, then your body is going to release ADH. So that way your kidney tubules will reabsorb more water out of what would have been the urine. So you're retaining water. So this is actually produced in the hypothalamus and it's actually secreted by the posterior pituitary. If you have not enough ADH, then you have a condition known as diabetes insipidus, not to be confused with diabetes mellitus. So there are a couple of different types, which you really don't have to get into for testing purposes, but I just want to explain them a little bit here. You can have central diabetes insipidus, which is where your body, your pituitary, is simply not making enough ADH. Or you can have the root source, be it the kidneys, that's referred to as nephrogenic. It simply means, okay, you're making ADH, but your kidneys aren't recognizing it. And then the interesting one, if you've ever had kids, you'll know about this. One of the things that will happen, you feel like you need to pee all the time. And a lot of that is because you've got a bowling ball sitting on your bladder, but some of that is because the placenta will actually make an enzyme that destroys ADH. And so that just kind of gives you the added pressure to have to get up and pee every hour when you're pregnant, just to add to the joy. So, and then the last type is actually a psychiatric issue. PUPD simply means you're drinking too much and peeing too much. Psychogenic simply means that it's coming from a psychiatric compulsion. So what happens is, again, you're going to be not able to regulate the amount of urine you're going to produce. Instead of producing a couple of liters a day, you'll be producing about 15 liters per day. The other hormone associated with the posterior pituitary gland is oxytocin. So the main thing we think about when we see oxytocin is stimulation of uterine contractions during labor. It also stimulates milk letdown when you're nursing a baby. So this is why I said don't be confusing prolactin with oxytocin. Prolactin, again, is going to give you the internal architecture enough to make milk, the milk ducts, etc. Oxytocin will allow milk letdown, so milk actually reaches the nipple and can be nursed out by the infant. This is also known as the cuddle drug because it's associated with human bonding. It's been shown that people who hold hands release higher levels of oxytocin. Those people are again, thought to be better bonded and have a more long-lasting relationship. They say if you snuggle with your significant other for at least 30 seconds to 60 seconds, you can stimulate oxytocin release. Of course, the trick is if you don't like that person to start with, that's a long 60 seconds. So they've actually shown by doing MRIs and blood tests and this sort of thing, if they show you a picture of your pet, that you release oxytocin. So even pet ownership is associated with bonding and release of oxytocin. And they're doing studies now in treating postpartum depression in mom-baby bonding issues with oxytocin injections. They've actually tried using inhalers of oxytocin in marital couples therapy. So let's move on from the pituitary glands now and start talking about some other hormone production. And we'll start out talking about calcium regulation. We've already talked about the fact that calcitonin is produced in the thyroid gland. On top of the thyroid gland, there's 4 to 5 little small glands known as the parathyroid glands. They actually will stimulate osteoclast activity, and they will increase circulating calcium in the bloodstream. We talked about earlier that the calcitonin will stimulate osteoblast activity, drive calcium into the bones. These do the opposite. So this is going to be released when you don't have enough calcium in your diet. Let's say you're sitting around drinking sodas and eating ho-hos, and you're not getting any exercise. Your body says, hey, I need some calcium to drive my nerves and to drive my muscles. And so your body says, okay, wait, I can break down some bone tissue, release some calcium and phosphorus, and you're all good to go. So the problem is, of course, you will end up with osteoporosis if this is a long-term activity here. So remember, parathyroid hormone is going to increase circulating calcium by breaking down bone tissue. And those are the osteoclasts that we talked about when we discussed bones. You also will actually increase the amount of calcium and magnesium that you absorb from your diet. There is a condition known as pseudohyperparathyroidism, and that's actually not rare. So pseudo means fake. We already know what parathyroid gland is, so hyper is too much. So with true hyperparathyroidism, you'd have too much activity of the parathyroid glands. You'd be breaking down too much bone tissue. But what happens, there are some cancers that will secrete a substance that mimics the parathyroid hormone. And a lot of times you'll actually have a patient that will go to the hospital with a broken bone. They have no idea they have cancer. And they will actually do a blood test on them, and they see the calcium is high. So there's no reason for these bone breaks due to osteoporosis. And but on x-rays, the bones will be very moth-eaten and very weakened. So if you had a case of true hyperparathyroidism, you'd have low calcium, but with pseudohyperparathyroidism, you'd have very high circulating calcium because you're breaking down all this bone tissue for no good reason. So this, again, can be associated with things like breast cancer. I will point out this definition in case you didn't pick it up. A pathologic fracture. A bone fracture can obviously be occurring to a normal bone, a healthy bone, from trauma. If it's a pathologic fracture, that means a fracture has occurred because the bone was sick. It was diseased. It might be sick due to true osteoporosis. It might be sick because it's infected. It might be sick because you have bone cancer. But it causes a very easy, serious break, and those types of breaks are known as pathologic fractures. Another hormone that regulates calcium is calcitriol. These are produced by the kidneys, and it's manufactured from vitamin D. And remember, you make vitamin D in your skin, and that's going to be facilitated by absorption of UV radiation, usually from the sun. Boy, I just noticed, I don't know what I was drinking when I was typing this, but I get a F on that spelling. So anyway, calcitriol will increase absorption of calcium, or calcium, as we now call it, from your diet in the small intestine. Okay, let's move away from calcium and talk about the thymus. We talked about this gland when we talked about the immune system. The thymus is in your mediastinum. In other words, it's in your thoracic cavity, sort of on the midline there, and it produces a hormone known as thymosin, and it functions in stimulating maturation of T cell lymphocytes. The gland is much more important as a child, and the older you get, the smaller it gets. By the time you get into your 70s, it's been mostly replaced with scar and fat tissue. This is one of the reasons elderly people are more susceptible to viruses, and they're also more susceptible to cancers because T cells are the cells that really help fight viral infections and cancers. The pineal gland is located in the epithalamus, behind the third ventricle, and this produces a hormone known as melatonin. Again, don't get that confused with melanin that we talked about from MSH in the anterior pituitary. Melatonin regulates your body's clock, internal clock, which is known as your circadian rhythm. It what makes us wake up at morning time, it makes us go to sleep at night, but it also has a tremendous number of effects from everything from when you have a bowel movement. It has an effect on your activity of your white blood cells, pain perception. You can clock everything very precisely with the normal circadian rhythm. Most babies are born in the wee hours of the morning. Most heart attacks happen certain times of the day. So again, it makes everything pretty predictable. Here's a closer look, and just as a reminder of your anatomy here, here is your thalamus, here is your hypothalamus, and then here is your epithalamus, and location of your pineal gland. This is just one of many maps you can find for your circadian rhythm. I find it kind of interesting. Again, most car wrecks happen wee hours of the morning. Most of your babies born around 4. Your highest risk of heart attacks around 4. You've got things starting to wake up. Your blood pressure is going to be going up. If you look here, the time sexual function in males is going to be a little bit more working, basically. Probably has a lot to do with testosterone secretion. I say if you go to the dentist, go about 2 o'clock in the afternoon. Your blood pressure is actually the highest late afternoon. Your higher body temperature is around 7 o'clock at night. This is why they say if you have a child and you're concerned about them running a fever, always check their temperature later in the day to be able to pick that up better. Let's move on now and talk about the pancreas. Most of the pancreas is actually associated with the digestive tract, and it has an exocrine function. It produces liters and liters of pancreatic juices that will break down fats and proteins. But what we're going to talk about in this chapter is the little 2% that is composed of endocrine tissue. The endocrine tissue is cells that are going to be located in what they refer to as islets. So that's islets as in little islands, as little clusters of cells. The hormone we associate most often with the pancreas is insulin, and this is associated with the absorptive phase. So when you eat a meal, it normally will stay in your system as far as you're absorbing nutrients from it for about 8 to 10 hours. That's known as the absorptive phase. You're going to be pushing blood glucose that you've absorbed into your cells, and that requires the hormone insulin. So this is going to be decreasing blood sugar. So think about an insulin injection for a diabetic. If you see an unregulated diabetic, they can have a blood glucose of sometimes several hundreds and even more, and it should be around 100, depending if you're fasting or not. I know with myself, I had a blood glucose last week. It wasn't fasting, and it was 86. So I have kind of the opposite problem. I can go into hypoglycemia, and you get kind of what I call the sugar shakes. So make sure you understand that insulin will decrease blood glucose. The other hormone associated with the pancreas is glucagon. This is released in the post-absorptive phase. Let's say it's now been 10 or 12 hours since you've eaten. You have nothing in your GI tract that you're absorbing anymore. But your body still needs that glucose. You've got to have that glucose for your brain and all the other functions that you're running. And so what will happen is glucagon will break down the glycogen that you've stored in your liver and in your skeletal tissues, and this will increase your blood glucose. So this is what's released when you're in a fasting type situation. Type 1 diabetes used to be known as juvenile diabetes, except they've discovered that it can happen at any age. This is also referred to as insulin-dependent diabetes because this is a medication, the insulin is a medication that can control this type of diabetes. So what happens here is your pancreas is simply not producing enough or not producing any insulin, and this might be from some sort of damage, viral infection of the pancreas. It might be some autoimmune issue that happened, or it might simply be a genetic issue. You'll also see this type of diabetes referred to as diabetes mellitus. That word actually comes from melon, melon being sweet, and evidently back in the days before they really had more advanced medical testing, the doctor could determine if the patient had diabetes mellitus by tasting the urine, and if it had a sweet flavor, then there you had your diagnosis. So the diabetes mellitus, what will happen is your blood sugar level will be so high that it spills over in the urine, and so that's one of the classic signs of diabetes is glycosuria. In this country, by far the most common type of diabetes mellitus is type 2 diabetes. This is referred to as non-insulin dependent diabetes. So their bodies are producing insulin, but it's not enough insulin, or the body cannot use it, and it's also referred to as insulin resistant. We could go on and talk about various hormones. They're discovering new hormones all the time. They've talked about hormones made by fat tissue, known as irisins, potentially some now made by skeletal muscle tissue, but we will mention a few more. Leptin is produced by fat tissue, and this has the job of reducing appetite. So you would think that somebody that was morbidly obese might not have enough leptin, but they've discovered that it's usually not a leptin deficiency. It's simply a lack of the right amount of functioning leptin detectors. Then the opposite of leptin would be ghrelin, and this will actually increase appetite. There are a lot more GI hormones. There are a lot more hormones related to blood production and blood pressure, and we have discussed those in other chapters, such as the GI chapter and the cardiovascular chapter. So we're going to conclude it here, and I will see you in the next one.